Good morning, and thank you for joining us for this episode of SBB Live's Doc Talk. We are very delighted today to bring on Dr. Omar Henriquez with Family Spine Institute. How are you this morning?
Doing great. Thank you for having me.
Wonderful. So today we are talking about compression fractures. This is something that your office that takes a holistic approach on. Tell me a little bit about yourself, and then let's get into our topic.
Sure, I'm Dr. Henriquez. I am double board certified in anesthesiology and interventional pain management. And so I work here at Family Spine and Pain Care Institute. And we basically take care of all types of pain, from neck to lower back to joints to arthritis to pretty much if you have pain, we can take care of it. So we try to, treat every patient as family, and we like it when patients come in and feel right at home. So I don't like them to feel like we're pushing them in and out, kind of like a factory. And we like to educate as well. So the more you guys know about what's happening, the better I think the outcomes would be. So we do take a lot of time on educating.
Yeah, it sounds like that's something that's really important to you. And I think, from working with us here at Seniors Blue Book, it's a passion of ours as well. We definitely want to make sure that, knowledge is power. You don't know what you don't know. So let's dive into today's topic and just talk to us about compression fractures and some of the other things that go along with that.
Sure. So basically, compression deformities occur, uh, and we're going to focus more on the spine, more on compression deformities in the spine. But what happens is when patients have osteopenia or osteoporosis, they're more likely to suffer these fractures. And so, where most patients end up fracturing is right here in the vertebral bodies. The more common places to fracture is right around the L1 or the T12, which is actually right above here. This is just the lower back here. But if we focus, let's say, on the L1, what ends up happening with a compression fracture is, let's say, someone with osteoporosis lifts something heavy and feels a pop in their back and severe pain immediately after. Or they take a fall, right? They slip and fall. And again, the pain is so severe and excruciating right in that back region to the point where they can't even stand or take a step. A lot of times, most physicians will get an X-ray, maybe an MRI. Sometimes X-rays can show a compression fracture deformity, and other times it will not. Sometimes the fracture is minimal to the point where you see how this is kind of like a cuboidal shape. When you fracture, a lot of times it ends up being more of a wedge shape, more of a triangular shape. If it is not severe, let's say you fractured it and you only had maybe 10% height loss, an X-ray sometimes can miss it. So sometimes I'll see patients that come in referred by their primary care doctor because they fell down having severe excruciating pain. They get an X-ray, they don't see a fracture. They see, maybe a little bit of arthritic changes in the spine back in here, maybe a little bit of disc degeneration, and they can't really figure out why the patient is having so much pain. So in that case, what you end up doing is getting an MRI, and an MRI will show a lot of fluid buildup within the bone itself, right? So fractures occur either from an accident or just ever so slightly, bending and lifting something in an awkward position, and all of a sudden it's severe pain. So usually patients with osteoporosis, osteopenia, or even cancer, so patients that have metastasis from one cancer from cancer into the bone, that cancer can actually weaken the bone, and then that can cause some issues too, like compression fractures. So ways to diagnose it would be images, X-rays and MRIs, like we just discussed. You can also get a CT scan. The MRI is the most specific one because the MRI will show some edema, which is kind of like inflammation or fluid within the bone itself. In order for us to be able to fix a fracture, two things, you need to have a couple of different things. Number one is the pain, should be pretty severe to the point where you can't really do much of your activities of daily living. Any motion or movement, usually going from sitting to standing, or even when you're sitting and kind of twisting, leads to a kind of like a sharp jab. If you're suffering from that type of pain, then definitely you want to get it fixed. The other thing is the MRI should show that everything is pretty much intact. Okay, so when you look at the spine here, the vertebrae, the outer part is the part that contains is the hard part of the bone. The inner part in here are like little spindles of calcification. And so what really ends up fracturing is not really the outer part, it's the inner part. And that fills with fluid and that causes pain. Well, we need to make sure that the outer part is intact before we do any type of procedure. And so we don't want any of these little bone spindles going back this way, getting close to that nerve, getting close to the spinal canal. So there's a couple ways of treating compression fractures. If you're in the, yeah, I have a compression fracture. I don't really have much back pain. It's there, I feel it, but it is getting better. If you're on that stage, then sometimes just putting on a back brace and watching what you do, and maybe taking an anti-inflammatory, a pain medication for about a month or two, basically takes care of it, because your own body will try to heal itself.
That's exactly what I was just about to ask you. Is this something that can heal itself if
Right.
you give the rest, which is incredibly difficult for someone like me to do. I'm just a go kind of.
Right, exactly. And so we gauge on how much pain the patient is in, and also how much activity can they do, because the last thing you want to do is have a patient suffering, not being able to get up and walk around, because then they can develop DVTs, deep venous thrombosis, blood clots, that type of deal. So if you're able to walk around and do things and it's not really bothering you so much, and you're seeing that it's just getting better and better, then just brace yourself and let it go. If it's not, if it's severe, if it's excruciating, if you can't get up to walk around, or if, let's say, it happened about 2-3 weeks ago and it's just not getting better, then we probably do have to fix this problem. And one way of fixing it is called a kyphoplasty procedure. And what a kyphoplasty procedure is, it's basically us going in through here into the area where the fracture is located, and we inflate this balloon. And so in inflating the balloon, what we're trying to do is, remember, when you have a fracture, the bone is actually wedge shaped, kind of like triangular shaped. So I'm going right in there and I'm inflating the balloon to try to augment the space of the bone. As we inflate the balloon inside of here creates a cavity as well. So that cavity, we deflate the balloon, that cavity stays there, and then we go in again and we inject, we'll call it synthetic cement, which is basically what will burn all the nerves inside of the bone, but also stabilize the bone itself, right? And when I say burn the nerves, I'm talking about the pain that you're feeling pretty much almost immediately goes away. So you're looking at possibly 10 minutes after the procedure, the patient probably came in with, in a wheelchair, couldn't walk, couldn't do anything. And then, 10 minutes after the procedure, they're out there and walking and feeling pretty good, actually.
Wow.
Yeah.
That's
So,
crazy. Yeah,
yeah.
it sounds like a pretty intense procedure. So it's not painful, you would
It's
say?
not. So for this procedure, most of the procedures that we do here, I do them in my clinic, and we don't use any no sedation. We don't put the patients to sleep. We do like all the injections and everything awake. And really, after you've had it done, you're going to say, well, that's it. I mean, why was I put to sleep? Maybe a little Xanax will help you relax a little bit. But
Yeah, I
for the
would definitely be
kyphoplasty,
taking that.
yeah, yeah. But for the kyphoplasty, you do need some sedation. So we have the anesthesiologist come in. We, give you a little bit of pain medication, because it does hurt, right? And so we give you pain medication through the IV, a little bit of propofol to help you sleep during the procedure, and then we get the procedure done. So you're basically not awake during the procedure. You're kind of semi-awake, like in twilight.
Mhm.
But like I said, immediately after the procedure, you're up and moving, and it feels real good.
Interesting. Now, is this two questions? Is this something that is covered by Medicare or regular insurance? And also, are these type of fractures more common as you get older, or it could happen to anyone?
Yeah, so so yes, it's covered by Medicare and all major insurances. You just have to show that, look, patients in pain, there is an actual acute fracture, because that's the other thing that I forgot to mention is there's a window. There's a window of time of us being able to do this procedure. Usually we don't want to wait more than 6 weeks, right? Because by then your own body's trying to cause, calcify the bone itself, and it's trying to heal itself, right? So you don't want to disrupt that. But within a 6 week window, it's perfect, and you can go in there, and most patients end up having real good outcomes within that time period. So yes, so as long as you're showing all of that, Medicare and all commercial insurances do cover this procedure. As far as who are at higher risk, obviously the older you get, the weaker our bones end up getting. And so, like I had mentioned in the beginning, osteoporosis, osteopenia patients that have weakness in the bones are more prone to getting these fractures. Now, younger patients can also get these fractures, mostly from injuries, right? So you have traumatic fractures, and then you have pathologic fractures from osteoporosis, osteopenia. Those are the ones that we see more common, but we do see some young, when I say young, I'm talking about 40, 50-year-olds who, they fell, got into a car accident, whatever it is, and they ended up suffering these compression fractures, so we end up fixing them as well.
Yeah, this has been incredibly informative. I love interviewing you guys. It's so interesting. I feel like I learned so much every time I do one of these doc talks or just educational videos in general. You did such a great job explaining this. I just want to thank you so much for coming on the show this morning. And until our next doc talk, if you have questions, please put them in the chat, and we will make sure to get them over to your office there. Thank you so
Yeah,
much.
absolutely. Thank you for having me. And if they have, the other thing that would help is if we do this again, any other topic that, patients are interested in, we can
Absolutely. Put it in the chat. We want to hear from you for sure.